noted this morning, those cells aren't very adherent, so fluid can get through those cells very easily and then collect in the cornea. We also wanted to limit the amount of time that we're in the eye and limit the amount of time that we're sculpting that nucleus, because we don't want a lot of heat energy to damage the cornea. And then obviously the post-operative medication regimen that we now have, steroids and Euro, which we'll talk about here later. So what is my surgical decision tree, or anyone that's taken out a cataract in this particular circumstance? This is obviously what we want to see, a nice, perfectly clear cornea with a beautiful lens implant sitting in there. So that's one way that we can go, cataract removal and lens implantation. And obviously the other way to go is what's known as a triple procedure, where we take the cornea off and then take the cataract out underneath it and put a lens implant in, and then sew a cornea transplant back on. So preoperative considerations. Another slide here for Hank. Slit lamp exam, very important. The slit lamp is actually the ophthalmologist's best tool in the office. There are so many things that we can pick up from that lamp, so many different ways that we can use the light, so many different magnifications. And actually, the best way to check specular microscopy, and the easiest way, is with a slit lamp. You can actually turn on high power and look at those cells and look for that hexagonal pattern. And if you've been trained appropriately, you can see that without an endothelial cell density counter. We want to look at how much guttata are there. We want to look at the presence of edema. Is there a lot of stromal edema or a lot of epithelial edema? That person might not do well with just cataract surgery alone. Is there a lot of scarring, like that stage 4 picture that I showed you? If there's a lot of scarring, the vision into the cataract may be very difficult. It may be hard to see the cataract and hard to get it out. So that may be another person that might do better with a triple procedure. Specular microscopy, not only the slit lamp view, but we now have very high-profile endothelial cell density counters, which can actually take a picture of the map. We mentioned that this should be a tool for every ophthalmologist. If you can use the slit lamp and actually look at someone clinically, I think there's a very high correlative pattern to what we see with our eyes and what we see with the slit lamp, to what we see when we get that endothelial cell density counter. And I guess if my mentors, Mark Maness and Ivan Schwab, Mark Maness used to be the president of the Eye Bank Association, I think when they give an endothelial cell density counter, I'll probably buy one too, but right now I can get a very good look at what I'm doing at the slit lamp and can figure out what I need to do on my decision pattern. And this is the tool that I like to use. Corneal pachymetry is very essential in determining who is going to succeed with cataract surgery and who is not. This actually shows you an average normal corneal thickness, which really ranges about 525 to 550 microns. We had a study here in Duane's that came out actually this is a chapter in Duane's in 2003, which has suggested through various papers and various research, of which Hank has been a part of as well. We used to think that if the corneal pachymetry, that central corneal thickness measured by ultrasound, if it was greater than 600 microns, we would recommend a triple procedure. So the pachymetry becomes a very essential tool in evaluating patients with cataract surgery and Fuchs dystrophy. The other group that Hank mentioned, the group at Wilmer, has just recently come out with a paper in March of 2005, which actually suggests that this number could easily be raised to 640 microns. And they had essentially about a 90% success rate if the pachymetry value was less than 640 microns of not having corneal problems post-cataract surgery. And this is really more the number that I use in my practice today, is the 640. So how can we mentioned altering your incision technique. How does that play a role in surgery in this setting? There are really 3 patterns of incisions that we can make into the eye. Probably the oldest way is making an incision in the white part of the eye, the sclera. And obviously the benefits of that is you totally avoid the cornea. You don't touch it at all. You still have irrigation fluid coming from inside the eye, so there's still a potential to hurt the cornea, but you haven't altered the endothelial cells by actually mechanically touching them. this has also been developed to what's called a near clear corneal incision. You can see here, right there where the incision is, it's just between the sclera and the cornea, so almost corneal incision, but not quite. Maybe a little bit more of those peripheral endothelial cells, as we heard about last time that you heard mention of, but this does provide more protection versus this newer technique that's probably done 75% of the time in today's modern era. This is just a clear corneal incision. And you can imagine this is a diamond knife that we typically use for all of our cataract surgery cases. It makes a very precise incision, but even that precise incision is going through the endothelium and getting some of those endothelial cells. So if I have someone with Fuchs dystrophy, I don't really want to use that technique. I want to preserve as much endothelium as I can. And just to show you, this is the old intercapsular cataract incision. You can see here, wow, we don't do this anymore. It's a very large incision, a lot of stitches in the eye. And it takes a long time to get the vision back. I mentioned ophthalmic visco surgical devices. These used to be known as viscoelastics, but this is kind of the name that's becoming the commonplace today. These are actually devices that are made with a material hyaluronidase, which is actually in our skin and in our body. There are other components as well, chondroitin sulfate and other materials. And these are essentially like a gel, a protective gel, that every ophthalmologist uses these. If anybody's ever taken out a cataract, they've used these in the last 15 years. But there are different types, and I won't get into the logistics of these devices, but they're essentially two. There's a cohesive group and a dispersive group. The cohesive group is very thick. It gives a lot of form to the eye, and it's good for giving the eye good shape, but it's very easy to come out with irrigation fluid. A dispersive agent, as you can imagine from the name, disperses very well. It coats the endothelium, and as you can see here, this has formed a protective shell around the cornea, especially on the endothelium. Look how that's coated there. When the instrument's in the eye, you've got a complete protective coat, trying to absorb that heat energy so that it doesn't hit the endothelium. This is a dispersive agent that we typically use in our practice called visco. There are several other ones around, but this one works, I think, in particular well with Fuchs dystrophy. We also mentioned phaco-dynamics, the phaco machine, the phaco-emulsification unit. We want to limit our irrigation time. As you can see here, this is the tip in the eye, taking out this rather dense cataract. And this has ports on the side which provide irrigation and aspiration through the main tip here. So you want to limit the amount of irrigation you use in the eye, and you want to limit the ultrasound time. And obviously you want to use low power ultrasound settings because you don't want that heat getting to the endothelium.
What kind of temperature are you talking about for heat?
It's a good question. I would guess probably about it's a little higher than body temperature. Your body temperature measures 96.8 degrees Fahrenheit. So it's going to be considerably higher than that, and that's why we want to use those viscodispersive agents to protect that. Another important thing with our development of pharmacological agents over the last 10 to 20 years, all of you know this one very well. I use this a lot in my post-Fuchs patient cataract surgery cases, and typically use the drop form and some ointment at bedtime because that really helps the cornea to get its normal physiological state a lot quicker. And then obviously these corticosteroids, Preoperative is what we typically will use after any ophthalmic surgery. But in particular, I will use this quite frequently, maybe every 2 to 3 hours in patients who have had cataract surgery and Fuchs to really help those junctions kind of close. We don't want more fluid to get into the eye than needs to be necessary. So in summary, cataract surgery in Fuchs dystrophy patients can cause corneal decompensation. That's a known variable. But we certainly have techniques that we can use now to limit the amount of endothelial cell damage. And those involve also very careful planning, careful decision making, careful evaluation of all those instruments, all the measurements that we've done, corneal pachymetry, speculum microscopy, looking at that slit lamp. All those things are extremely important in determining which step we go, cataract surgery alone or cataract and cornea combined. And then certainly these advances like viscosurgical devices and the newer ultrasound phacoemulsification units that are being new ones made every year or two. There's even now a machine called cold phaco, which can actually limit that heat, the amount of energy that's in the eye, to much lower than the physiological level. So I think we've come a long way with this. There's still always risks involved when you undertake this procedure, and it's very important to have a good communication between you and your physician. You know, it's a team process when you decide on this, and that's the most important thing to remember. So I thank you all. And, I have some questions here.
How long in time does the surgery take itself, the actual procedure? Does that make a difference?
It sure does.
How long in time should this procedure take?
How long should the procedure take? It is a variable procedure, and it depends on how big the cataract is, how hard is your view. But typically cataract surgery today can go anywhere from 10 minutes to probably 20 minutes. Some difficult cases where the cataract's much more dense and it's gone along longer may take up to 30. But the real key, if the case is taking longer and it's a bigger cataract, you know you have to use less heat energy, use a slower amount of force, and you may even want to, if it's a larger cataract, you may even want to alter your technique and do that extra capsular technique rather than using the phaco machine to totally avoid any heat exposure. That's a good question. So it's variable, but I would say 10 to 30 minutes. Most of them probably be in 10 to 15 minutes. So,
Two questions unrelated. Can Pret Forte after the DLEC procedure, can too much of that cause a cataract or stimulate a cataract? Then unrelated to that, if you have cataract surgery, I understand there's a newer lens that will change. It's not a fixed long distance or short distance.
right.
Any discussion about that? I don't know what
Sure.
you call the name of it, but you might.
I guess the answer to that first question, let me answer the last one first. I guess you're probably talking about the Restore lens, the accommodating lens.
I think so.
There's several different of these out. I guess about 8 or 10 years ago, the first lens came out called the Array lens, which was felt to be a accommodating type of a lens implant. For those of you who've had cataract surgery, you'll notice once you've had that lens implant put in, you kind of completely lose that ability to read up close, even though you can see pretty well. You lose that ability to accommodate, which is what we do when we read up close. We also lose accommodation with age when we hit our 40s. So there are some lens implants out now. The Restore lens in particular, there's another one called the Resume lens, which are now, the Restore lens in particular is called an adaptized lens, which actually helps you have good distance vision and fairly good reading vision. It's not a perfect 20/20, but the ones that we've done, I think pretty much all of them now are 20/25 or 20/30 up close. So that's amazing. I mean, it used to be nothing up close with routine cataract surgery. How will that lens be affected in someone with an abnormal cornea? That's a good question. I don't think that there's a lot of data out on that now. The FDA trial on the Restore lens pretty much required that everyone's eye be normal. So I doubt that that's been put in anybody with Fuchs, but certainly it wouldn't be a contraindication to it. Just the cornea may prevent you from having that perfect vision like you'd like. What was your first question?
And then Pret Forte, can you overdose on that sort of to stimulate a cataract? Can you get too much?
I guess you could possibly overdose on it, but I'll tell you, many corneal surgeons in the country, when they do a typical traditional cornea transplant, will do Pret Forte every 2 hours for the first month. So even though steroids do have side effects of causing cataracts, of causing high pressure, glaucoma, things like that, you really have to weigh the risks and benefits of using them. And after transplantation, it's much more beneficial to use them rather than harmful. But it could potentially cause a cataract, and in particular, steroids typically cause a posterior cataract, which is very easy to pick up. That's just something that your ophthalmologist has to keep an eye at, and that's something I look at in all my transplant patients that are on Pret Forte, because some people are on this for their life after a transplant. Some people are fortunate enough that we can maybe take them off of it, but that's certainly a worry about cataracts long term. It's a good question.
Is there any special,
Go ahead.
is there any special consideration for people that have already had a transplant? It's an older transplant?
That's a very good question. You know, you certainly worry, as we've seen from the slides, every year you're going to lose some of those cells, and we know that after transplantation you don't have a normal amount of cells, even if you have a beautiful corneal transplant. And there certainly can be risk to doing that. If I do cataract surgery in someone who's already had a transplant, I always pretty much use that scleral tunnel incision to completely stay away from the cornea. Use a lot of that viscodispersive agent, and try to use very low phaco power. It's really the same as it is with this cataract surgery that I mentioned to you, but you just want to be very protective of that cornea transplant, because it is a potential risk that with cataract surgery your cornea may decompensate. So that's something to think about.
Should a slit lamp exam be done every time a Fuchs patient comes in?
Most definitely.
At every visit?
Mm-hmm. Should be done every time.
Can you change the interocular lenses if you've already had cataract surgery? Can you go to one of the newer lenses?
You can. I'll tell you, in this group in particular, though, the more times you enter that eye, the more endothelial cells you lose, the more risk of that cornea is going to decompensate. So it's going to take me a lot to go back in someone's eye to do a lens exchange in your particular case. It can be done. It can be traumatic. Sometimes when you're taking that lens out, it may be a lot of scar tissue. You may have to do a lot of dissection, and you could even compromise that bag that the lens sits into and break it. So it's not something to go into without thinking through it pretty well about the consequences down the road.
Just a point, would you mind repeating the question to the...
Oh, sure. Sorry. So they asked about my last answer was, can you go back into the eye and take out a lens and exchange it once one's already been put in? Very risky in someone in your own situation.
What are the pros and cons for having a cataract removed at the time of transplant versus having the cataract removed later?
So pros and cons of cataract surgery and then transplantation maybe later versus transplant and the cataract together?
Right.
Okay.
So we're doing the cataract after transplant.
Well, obviously the cons of doing the cataract after transplantation would be what we talked about earlier, that you could potentially make that transplant degenerate. I wouldn't say reject's not really the word to use. It's more degenerate from losing those endothelial cells. That's certainly the biggest thing to think about in doing cataract surgery later. But you just have to gauge that based on what the vision is. Obviously, if the vision's down, then we can help you by taking the cataract out. Many times it's worth that risk of doing it. You just have to be very protective. The beauty of that is, for those of you who have a transplant, almost everyone with a transplant is myopic, which means difficult to see far away, and has astigmatism. That's just unfortunately one of the side effects of transplantation. And what we can do going back later, after a transplant, taking out a cataract, is we can fine-tune that myopia, that nearsightedness, with our lens implant. And I think Ed Hall in Cincinnati has described several papers on that too, where he's actually doing this a lot more now, going back in, doing the transplant first, even if there's a little bit of a cataract, going back a year or two later once the wound's stable, and putting in a lens implant in to help correct some of that nearsightedness. Now that lens won't correct your astigmatism unless it's, there are some lens implants out now that are called toric. For those of you who know what toric corrects astigmatism. So that's certainly an option down the road too. So, and then obviously a triple procedure, you get everything done all at once, so that's nice, but it's a little tougher for you, a little bit more risk to do a triple procedure. That eye's, you know, when you take that cornea off, there's not much holding the contents of the eye in. And all of us corneal surgeons like to get that cornea on. Our heart rate goes up pretty quick when that cornea comes off, because we really have a fine window to get that cornea back on. And so when I'm doing a cataract surgery, that eye's open for, I said, 15 to 20 minutes. And you get that heart pumping a little bit, because we want you guys to get in and out of there as quick as we can. So that's obviously one of the disadvantages of doing a triple procedure, but certainly the advantage is that you can get it all done with it once. The other disadvantage of that is you're probably still going to be nearsighted because we're going to correct you for what your vision is now. You're still going to be nearsighted from the transplant down the road, so you'll probably still need to wear glasses or a contact lens down the road. In the back. I showed a slide on it. We call it a triple procedure when anytime we do a cataract surgery, put in a lens implant, and do the cornea transplant. So 3 things at once. So we tend to call that the triple procedure or combined procedure. Right there. Yeah. I heard the chemotherapy part. That's a good question. I actually have dealt with this 3 or 4 times this year, patients that are needing a transplant under chemotherapy. And I can tell you the biggest thing post-operatively is that the transplant is very dry. We like that epithelium, that top layer, to grow back as quick as we can. With chemotherapy, those medications all have side effects of dry eyes. So it takes a little bit longer for your epithelium to grow back over your graft. You're going to battle dry eyes probably for a good month or so. A lot of artificial tears, which are preservative-free. A lot of lubricants, as much as you can put in. And that's the biggest thing that you battle. It certainly can be done. What I do is I stage it between the chemotherapy treatments and try to space it right in the center so that you have some time after and some time before the procedure to heal up. But that's definitely the biggest thing is the dry surface of the graft.
Do you know whether it affects acceleration, whether chemo has an effect on acceleration of the endothelial cell loss in the Fuchs?
I'm not aware. Hank probably is good to ask. The question was, does chemotherapy affect the endothelium and does it have any adverse side effects? I'm not aware of any known studies that have endothelial toxicity. There are certainly some medications that are endothelial toxic. For instance, those of you with glaucoma, carbonic anhydrase inhibitors, like Trusopt or Cosopt, may not be the best thing for you. But I'm not aware of any chemotherapy agents. The biggest thing that they do is just cause dry eye.
Which makes it seem worse.
Right. Makes that vision much longer to come back. It's very frustrating. In the back.
Yes, I want to know if you know if there's any connection with Fuchs dystrophy and the development of cataracts in earlier age.
There certainly is. We just know that the question was, is there a connection between people with Fuchs dystrophy and development of cataracts early on? And there definitely is a connection. I'm not sure we understand it completely, but definitely patients with Fuchs dystrophy do tend to get cataracts earlier. And I think Hank showed a slide there earlier talking about, I guess you can even think of the fluid coming into the cornea, fluid into the lens as well. That osmotic shift that he showed you where the sodium and potassium ions going through the lens and coming through the back. Maybe that's altered some way and there's just an imbalance in the lens and that cataract comes on earlier.